you've had a few really great successes in the last year or so. Your team won an Eye for Eye NIHR Product Development Award, and you've gone on this year to publish in the New England Journal of Medicine AI on a randomized controlled trial for your AI product. Could you tell us a little bit about what the product was doing, what you were testing, and what you found that the AI helped with?
Oh, yes, of course. I'd love to. So that study that we recently published in the New England Journal of Medicine AI was really a validation of the prototype that we had developed in the research setting. So before it was productized and, gone through regulatory approval, so very much pre-market. But essentially the device was doing the same thing as what we'll be using for the Eye for Eye trial. And that is as a workflow assistant for the fetal anomaly ultrasound scan. And I'm sure, of course, you know that that scan is one that's offered to all pregnant women at around 20 weeks of pregnancy, where we look at baby from top to toe, assessing if there are any conditions that potentially need follow-up or referral to our fetal medicine specialist or fetal cardiology specialist for review as well. So it's a really important scan to make sure we get right. But unfortunately, there is huge amounts of variability in that scan. And, even now with all the investment and knowledge that we have, detection rates for babies that have congenital heart defects, for example, who then go on to require surgery in the neonatal period, we pick up around 50% of those, and there's very wide regional variability. So this is a problem that's just not been solved. The fetal screening program is very well established, not just in the UK, but in most high-income countries. And we've not been able to crack that problem just yet. And this is no fault of the operators that, perform these scans. It's a difficult task in, a highly pressurized environment with a short window to really assess that baby. And you're not just looking, for example, at congenital heart defects, you're looking at all of baby from top to bottom. So in effect, you're looking for a needle in a haystack for conditions that are quite rare when you consider, we're screening a whole population group. So the first thing we wanted to do with the product was, one, support the sonographers in their scan. We know there's measurement variability, let alone diagnostic variability in terms of the screening. So the tool will, as the sonographer's scanning in, freehand mode, will automatically extract the standard planes that you need to collect for that examination automatically. And at the same time, it also measures the biometrics that are relevant for that particular scan. And there's a number of routine biometrics that you have to take as part of that examination, and can give you an indication of, if there's something that needs following up, if, baby's looking too small or too big. And what that means is that actually, instead of interrupting the sonographer's workflow, where they need to pause and scroll back and try and find that perfect image and just think about documentation rather than assessing the anatomy, that's now done by the tool that sits next to the sonographer. Same with the measurements. Instead of finding one good image to perform that biometric, that measurement of fetal anatomy, actually the machine is doing that in the background. And it's not just measuring one image, it's measuring tens or hundreds of images. And that means we can give a really confident assessment of the central estimate for that biometric, and we can also indicate the confidence interval, so how sure we are that that's the correct measurement, and that's because we can measure so many. So in this trial, that's essentially what we've done. It was a randomized controlled trial in a single centre. There were almost 80 participants that took part, with an enriched sample of patients that had confirmed congenital heart defects through their antenatal care. We also had almost 60 sonographers that took part in the study as well, and they were randomised to either perform the scan in a standard way, so doing their routine measurements and documentation, and of course assessing anatomy for anything worrisome. But we also then randomised our sonographers to using the AI assistant. What we found essentially was that the time to perform the scan and complete the report was far quicker, as you might expect, in the AI group. And that, I think we had a time saving of approximately 40%, so almost 10 minutes kind of shaved off the examination time,
Wow.
which is usually up to about 20 minutes. In that setting. So that's huge. Now we can have a separate discussion about what one might do with that time.
Yeah.
But, just to show that there is that potential of efficiency in there. The other thing we found was that the biometrics were highly repeatable and highly reproducible when using the AI tool. And of course, the benchmark is the manual scan, which the sonographers in this study, they performed 3 times. And then they chose the best one that would go into their report. That in theory should be best practice, but in the real world, people usually will just measure one image and save it to their report. Either way, we found that if you repeated that AI on that same patient on the same day, so, we did a repeatability study with the AI, it was highly correlated, much more so than the sonographer that was repeating their own measurements. And then when you compared the manual measurement from the sonographer to the AI result, again, was always within limits. And actually the AI result was much more within limits when you look at inter-observer variability. So if 2 different sonographers were performing the same measurements, and we used benchmarks that were in the published literature as well. One of the other things that we looked at was cognitive load. So the sonographers that were using the AI scan only had 15 minutes of training on how to use the device, but we still found a statistically significant difference in their cognitive load using a few different scales, one of them being the NASA TLX scale. And, the question is, okay, well, if your cognitive load is reduced when using a tool like this, and remember, it's just an assistant, it's just reducing the need to interrupt your workflow so you can focus on looking at the scan and looking at the anatomy. Using that, even as a new device, still reduced the cognitive load. And what we did see was an increase in the sensitivity of detection rates for congenital heart defects. So that increase in sensitivity, comparing the manual scan to the AI-supported scan, this is with no disease detection models in there, we saw, but the study was not powered to find smaller but even clinically significant differences. So it was powered to only see a 25% difference between those 2 groups, although less than that would still be statistically significant. So we need a much bigger trial to be able to really understand what the impact of that would be. And that's what we'll be doing with the Eye for Eye trial.